All right, good morning. It is March 14th. It is Pi Day. We already celebrated that in here. And this is Senate Health and Welfare. This morning, we are looking at our committee bill. Jen, thank you for the work that you've done to get this on in front of us this morning. Appreciate it.
All right, you ready?
You should go right ahead.
Okay, good morning, Jen Carvey from the Office of Legislative Counsel. We are looking at the committee bill. So it still has a draft request number because it hasn't been introduced. So it's draft request 250907. We're looking at draft 2.1, which is posted on your website.
You get a copy of that?
Yeah,
Right here. I have it. All right.
Yes.
Right on your desk.
I found it. So we need later.
Great. So I will put it up on the screen. And as I've done with other markups, I've tried to for a sec. So I try to show everything that is different in highlight and bold if it's new language, just struck through and highlighted if it is to come out of the bill. So this is an act relating to healthcare payment and delivery system reform. There are, based on some direction from the chair, there's a new first section on purpose and goals. And Madam Chair, I used your notes, but I wasn't quite sure how you saw it structured, so I made a few modifications, but we can make changes as we go through as well.
Yeah.
So it starts that the purpose of the act is to promote transformation of Vermont's healthcare system. In enacting this legislation, the General Assembly intends to advance the following goals. First, improvements in health outcomes, quality of care, and regional access to services. Second, an integrated system of care with robust care coordination and increased investments in primary care, home health care, and long-term care. 3, stabilizing healthcare providers, reducing commercial health insurance premiums, and managing hospital costs based on the total cost of care, beginning with reference-based pricing and continuing on to global hospital budgets. And 4, improving population health and increasing access to health insurance coverage. Then I've renumbered. So we have now section 2 is where we start getting into hospital budgets and payment reform. So the first changes there come with on page 3. I will just note, I think we talked about this a little bit yesterday, that some of the AHS proposed changes were to existing law around the Green Mountain Care Board's authorities. I did not limit that if that did not seem to be part of your discussion in here to limit their existing authorities, but just looking at their new authorities. So I did not make changes, for example, to strike the reference to methodologies for achieving payment reform and containing costs that may include the participation of Medicare and Medicaid, because we may get there. But just acknowledging that. But set rates for healthcare professionals pursuant to section 9376 to be implemented over time. And I've changed the beginning with reference-based pricing in 2025 to as soon as practicable, but not later than 2027.
We took out 25.
Yes.
Yeah.
Yes, so that's struck through and instead it's as soon as practicable, but not later than 2027. We have in reviewing and establishing hospital budgets, it talks about including establishing standards for global hospital budgets that reflect the implementation of reference-based pricing and the total cost of care targets. And there was some concern about whether we were appropriately including the participation in AHEAD. So I put in, at least for this draft, determined in collaboration with federal partners and other stakeholders, or as set by the statewide healthcare delivery plan once established.
The word partners is important there.
All right, then we have beginning, and in the last draft, it was beginning in hospital fiscal year 2028, recognizing that global hospital budgets may need to happen before that. For participation in AHEAD, this would say beginning not later than hospital fiscal year 2028, and as the board establishing global hospital budgets for one or more Vermont hospitals, not a minimum of 5, but still keeps by hospital fiscal year 2030, there would be global hospital budgets for all Vermont hospitals. Section 3 is where we get into reference-based pricing. So again, I've made no changes to the existing statutory language in that section. We've just added this new subsection E on reference-based pricing. I know we talked yesterday about whether to do things from the payer side or the provider side. At least for this point in time, I've stuck with the payer side. It can be developed more with more thought to be focused on the provider side, but that was not something I could figure out on my own last night. So I've left it as health insurers, but I did notice, because we talked about a broader definition of health insurer that would incorporate third-party administrators of self-funded plans to the extent permitted by law. And when I looked at the definition of health insurer in this chapter on the Vermont Care Board, that's already what it says. So by
Terrific.
using the term health insurers rather than payers,
Right.
we get that broader, sort of commercial and employer side payer to the extent permitted under federal law. So with all of that preamble, the board shall establish reference-based prices that represent the amounts that health insurers in this state shall pay to, and I've limited it here to hospitals, but kept the broader language below and we talked about adding items in addition to services. So items provided and services delivered in Vermont, not in Vermont residents, but in Vermont. The language is a little confusing here because it continues to talk about the sort of broader purposes of reference-based pricing with respect to healthcare professionals, which this chapter defines broadly to include individual healthcare practitioners and facilities like hospitals. So when it says healthcare professionals here, it includes hospitals. But I've left that language in because it's a sort of easy way to refer to the whole group. But in this description of the purposes of reference-based pricing, again, it's to contain costs and move healthcare professionals toward a site-neutral pricing structure while also allowing the board to differentiate prices among healthcare professionals based on factors such as demographics, population health in a given hospital service area. And I've added in a couple of places some recommendations, I think from the hospitals, to include payer mix, acuity, social risk factors, and a specific, and I changed provider to healthcare professional to be consistent with healthcare professionals' role in our healthcare system. And it requires the board to consult with health insurers, hospitals, other healthcare professionals as applicable, the Office of the Healthcare Advocate, and the Agency of Human Services on ways to approach reference-based pricing in an effort to achieve all payer alignment. In subdivision 2, I've broken it out into a few pieces because it got pretty long. So first, reference-based pricing established pursuant to this subsection shall be based on a percentage of the Medicare reimbursement rate for the same, and I've added, or a similar item or service, provided that after the board establishes initial prices referenced to Medicare, it may opt to update the prices in the future based on a reasonable rate of growth separate from Medicare rates. And then I put in that language from suggested by the Medical Society, such as the Medicare Economic Index Measure of Inflation. I don't think they had such as, but we talked about putting in such as, in order to provide predictability and consistency for healthcare professionals and payers and protect against federal funding pressures that may impact Medicare rates in an unpredictable manner. And then I've added in establishing reference-based prices. The board, and this is kind of what it was describing and what reference-based pricing is, but it seemed important to repeat that the board should consider it. The board shall consider the composition of the community served by the hospital, including the health of the population, demographic characteristics, acuity, payer mix, labor costs, social risk factors, and other factors that may affect the costs of providing care in the hospital service area. And this is to recognize that there may need to be different reference-based pricing, different percentages of Medicare that make sense in different parts of the state, depending on who they're serving. Then we have the board beginning to implement reference-based pricing by establishing the amounts that health insurers in the state shall pay to Vermont hospitals for added items provided and services delivered to individuals covered by the health insurer's plans as soon as practicable, but not later than we move this to hospital fiscal year 2027. Which begins in the fall of 26 and goes through fall of 27 into the fall. Then in new language, the board shall implement reference-based pricing in a manner that does not allow hospitals to charge or collect from patients any amount in excess of the reference-based amount established by the board for the item provided or service delivered. This is the no balance billing language, and I modeled it on language we have in Title 33 that sort of reiterates a prohibition on balance billing in Medicare. Also new language, the board, in collaboration with the Department of Financial Regulation, shall monitor the implementation of reference-based pricing to ensure that any decreased prices paid to hospitals result in commensurate decreases in health insurance premiums. And the board shall post its findings regarding the alignment between price decreases and premium decreases annually on its website. So some language proposed by the hospitals. I think they wanted an additional, that I did not put in here, but want to flag for you in case you want to, an additional sort of trigger. It didn't seem to me to be specific enough, but trigger for stopping reference-based pricing if the board thought it was a problem. Now, I think you could flesh that out more if you wish. Also new language, the board shall identify factors that would, oh, here's correct, where I guess I put it, but identify factors that would necessitate terminating the use of reference-based pricing in one or more hospitals, such as a reduction in access to or quality of care. I think that's where the Hospital Association wanted more of an automatic trigger, but I don't know what that would look like at this point. Then this is changed from the board in consultation with the blueprint to the Agency of Human Services in consultation with the Green Mountain Care Board, and changing from a shall to a may implement reference-based pricing for services. And I've changed from non-hospital services to services delivered outside a hospital, such as primary care services, and may increase or decrease the percentage of Medicare or another benchmark as appropriate. And left in language first to enhance access to primary care, later for alignment with statewide healthcare delivery plan once established. And I've struck the language allowing the board to enter into contracts because the board can do that without the obligation. Want me to just keep going? Do you want me to stop?
So far,
questions?
so
Okay.
good. If anyone has a question, they'll just raise their hand and ask.
Section 4 is what the hospitals have to file with the board.
Why did you have it for?
Sorry,
Why did you have it for there?
where are you?
Section 4.
Because you're changing the number when you take number 5 out.
Oh, got it.
Okay, it's 8 o'clock.
I know. It's page 9, line 4 or 5.
Oh, the only thing that's highlighted is the number.
Right.
Yes.
She just likes to have it.
That's just to indicate that the number has changed. So anybody who's focused on the section numbers from the last bill, section numbers have changed. Kind of highlight anything I change in here. That there's transparency. All right, so the hospital duties and the information that the hospitals have to file with the board. We've not made any changes about the numbers of employees and information on salaries in this part, but I have moved that idea about that had been in the board review piece in the next section, and now is in that you wanted to move to the hospital section about how they're going to invest. Or it was develop incentives for hospitals to support community-based. So instead I've changed this to proposals for ways in which the hospital can support, and otherwise basically left that language, can support community-based, independent, and non-hospital providers, including mental health and substance use disorder treatment providers, primary care providers, long-term care providers, and physical therapists, services provided through the blueprint, choices for care and SASH, investments in healthcare workforce, and other non-hospital aspects of Vermont's health and human services systems that affect population health outcomes, including the social drivers of health. And then 10 is renumbered. We've also modified the language on the uniform system of accounts concept to instead say, hospitals shall submit information as directed by the board in order to maximize hospital budget data standardization and allow the board to make direct comparisons of hospital expenses across the healthcare system. We hadn't necessarily talked about leaving that second piece in, but I think that was the rationale, so I thought it made sense to continue to refer to that. Section 5 is the board's budget review. So I struck the language about the uniform system of accounts. We've just put that in the way that hospitals submit their information, and at the end of the bill, you'll see something for the board to do that. I've just added in the once established and the reference to the statewide healthcare delivery plan here on page 11, and struck the language in subdivision 7 that we moved to the previous section. So instead of developing incentives for hospitals, it was having the hospitals provide that information. I have included in here, because you talked about this yesterday, that the board would that lead in conjunction with budget reviews, the board shall, and so this new number 7 is based on some language proposed by the Medical Society, exclude revenue derived from primary care, mental health care, and substance use disorder treatment services when determining a hospital's net patient revenue and any total cost of care targets. And that idea comes up again later in the plan.
Judge, that's a quick question.
Yeah.
For my own edification, on page 10, when we're talking about the healthcare system, that's Vermont's healthcare system, right? Correct.
Generally,
Okay.
yes. I mean, that's the system we have control over.
Yep.
Although, it's possible there could be. I mean, they do look at money that goes out of the state as well and comes in from outside of the state. All right, we are on page 13. Page 13 under consider the salaries for hospitals, executive and clinical leadership. I've added language suggested by the board, including variable payments and incentive plans. In number 17, where they consider the number of employees whose duties are primarily administrative versus direct care, I've struck the language about national averages. The board said it was not something we could do. In subsection C, about establishment of individual hospital budgets, they are to be consistent, and I've added to the extent practicable here with the statewide healthcare delivery plan once established, including the total cost of care targets, and with the health resource allocation plan, so that to the extent practicable is largely in there for the statewide healthcare delivery plan. And then I've added, so new seven is no longer the last one. There's a new 8 that the board requested, which is include meaningful variable payments and incentive plans for hospitals that are consistent with this section and with the principles for healthcare reform expressed in section 9371 of this title, which is the Act 48 principles. Now we're in subsection D, where the board annually establishes a budget for each hospital. New language says beginning instead of in hospital fiscal year 2028, it's not later than hospital fiscal year 2028, similar to the language we saw at the beginning. The board shall establish global hospital budgets for, and again, the change from not fewer than 5 to 1 or more Vermont hospitals that are not critical access hospitals, and then kept the not later than hospital fiscal year 2030 for all Vermont hospitals. And I've included in here because the Agency of Human Services wanted to be clear that Medicaid was not in here. But I also wanted to recognize that Medicare may be included if we're participating in a model that allows that. So global hospital budgets established pursuant to this section shall include Medicare to the extent permitted under federal law, but shall not include Medicaid. In subsection E, made some changes to the outcome measurement language. This is the piece yesterday we were looking at not using established because they already have some outcome measures, but also looking at ways to have some meaningful measurements. So I said in the board in consultation with the PQHC shall utilize mechanisms to measure hospital cost, quality, and access and alignment with the statewide healthcare delivery plan once established. Subdivision 2, I've broken this out. This is around the notice of reduction or elimination of services, and subdivision D, just a preview, is where we're going to talk about the reductions or eliminations as a result of the hospital transformation work, not having to do this process. So except as provided in subdivision D, a hospital that proposes to reduce or eliminate any service in order to comply with the budget must provide that same notice of intent to the board, the Agency of Human Services, the Office of the Healthcare Advocate, and the legislative delegation. And then I've broken out and put as its own, as a new subdivision, the notice shall explain the rationale for the proposed reduction or elimination and describe how it is consistent with the statewide healthcare delivery plan once established and the hospital's most recent community health needs assessment conducted pursuant to state and federal law. And then as its own subdivision here, changing from shall to may, the board may evaluate the proposed reduction or elimination for consistency with the statewide healthcare delivery plan and the community health needs assessment, and may modify the hospital's budget or take additional actions as the board deems appropriate to preserve access to necessary services. And the top of page 17 is the new D that says a service that has been identified for reduction or elimination in connection with the transformation efforts undertaken by the board and the Agency of Human Services under Act 167 does not need to comply with the provisions with subdivisions A through C.
It's a question I have there, Jen. I was thinking about Act 51. Does that belong in here as well?
I don't know that it needs to be Act 51. I believe amended Act 167.
Yeah, so it's all, okay.
So, I mean, we could say as amended by Act 51, but we refer to Act 167 a lot.
Yeah,
I don't know that it's necessary, but I'm happy to put it in if that would.
I don't know, because every time I know that the board and the agency continue to mention Act 51 as being significant. And,
Right, but Act 51,
Yeah,
as I recall, went into Act 167 and
Yeah, it
added a
did.
section that wasn't
Yeah.
in it, which is sort of confusing.
I'm fine with it.
All right, then we have the board in collaboration with Department of Financial Regulation, monitoring the implementation of any authorized decrease in hospital services. And I took out the language saying that to ensure that it either results in a commensurate decrease in premiums or in investments that support primary care and population health, and instead say determine its benefits to Vermonters or to Vermont's healthcare system or both. All right, and we're in section 6. This is the hospital network language, and I've added some additional provisions. Some of these are, at least the first one is also for consistency with the bill that they are working on in House Healthcare that will likely come to you after crossover, dealing also with hospital networks. So making sure we're using a consistent definition. So as used in this section, hospital network means a system comprising 2 or more affiliated hospitals and may include other healthcare professionals and facilities that derives 50% or more of its operating revenue at the consolidated network level from Vermont hospitals, and in which the affiliated hospitals deliver healthcare services in a coordinated manner using an integrated financial and governance structure. So there's new language allowing the board to review and evaluate the structure of a hospital network. And this is based on language that the board had recommended to determine whether any network operation should be organized and operated out of a hospital instead of at the network, and whether the existence and operation of a network provides value to Vermonters, is in the public interest, and is consistent with the principles for healthcare reform expressed in section 9371 and with the statewide healthcare delivery plan once established. And I've modified the language about the board in order to protect the public interest may investigate the financial operations of a hospital network, and specifically we talked about referring to compensation. So I've said including compensation of the network's employees and executive leadership. And then in subsection D, the board may recommend or take appropriate action as necessary to correct any aspect of the structure of a hospital network or its financial operations that are inconsistent with the principles for healthcare reform or with the statewide healthcare delivery plan once established. And then I've added in that any final action, order, or other determination by the board pursuant to this section shall be subject to appeal in accordance with the board's appeal provisions. All right, Madam Chair, this is your healthcare contracts piece. I've just put in a very small. I looked back at what we've done in past bills. A lot of it was looking at fee schedule, which I don't think was necessarily what you're talking about at this point. So I've just put in a standalone section here that would amend the Fair Contract Standard statute to, as we had looked at in a bill 4 years ago, I think, strike language saying that certain requirements do not prohibit a contracting entity from requiring a reasonable confidentiality agreement between the provider and contracting entity regarding the terms of the proposed healthcare contract. That was and sort of looking for transparency, and then adding, upon request, a contracting entity or provider shall provide an unredacted copy of an executed or proposed healthcare contract to the Department of Financial Regulation or the Green Care Board or both.
I like that better than the other.
Now we get into the statewide healthcare delivery plan and the advisory committee and renumbering. So now we have the Agency of Human Services in collaboration with the Green Care Board, Department of Financial Regulation, BPQHC. I've added the Office of the Healthcare Advocate, the Healthcare Delivery Advisory Committee, and other interested stakeholders shall lead development of an integrated statewide healthcare delivery plan as set forth in this section. The plan shall align with principles for healthcare reform. I'm just trying to be consistent everywhere else. I typically say expressed in. So expressed in section 9371 of this title. Here I've changed ensure access to promote access to high quality, cost effective, various types of care across
That's
Vermont.
a beautiful word.
And in 3, I said strive to make mental health services, substance use disorder, et cetera, available in each region of Vermont. So no more insurance. Provide annual targets for total cost of care across the healthcare system and include reasonable annual cost growth rates, taken out the language about bringing spending to in its relation to GDP, and instead added in that concept that we looked at in the budget piece, while excluding from hospital total cost of care targets all revenue derived from a hospital's investments in primary care, mental health care, and substance use disorder treatment services. All right, then we have no changes for a while, the whole page. Then we get to page 23, and I've taken out the reference to the board providing assistance, and since it's just the Agency of Human Services leading this, we don't need to specify who's supporting the work. And then I've taken out the references in the timeline to the board because it's really the Agency of Human Services that will be leading this work. Section 9 is the Healthcare Delivery Advisory Committee, and I've added, based on a request from the hospitals, that the committee establish affordability benchmarks, including for affordability of commercial health insurance, and renumbered remaining provisions. In subsection B, so here's one I put something. So most of this is based on the Rural Health Services Task Force. But there are a couple of things, so I wanted the committee to particularly, and others to particularly look at these. The 14 members, Secretary of Human Services or designee, Chair of Green Care Board or designee, Chief Healthcare Advocate from the Office of the Healthcare Advocate or designee. This is new, so I put one representative of commercial health insurers offering major medical health insurance plans in Vermont, selected by the Commissioner of Financial Regulation. And then here's the other piece. The Rural Health Services Task Force had 2 representatives of Vermont hospitals. So I put them in here because the criteria seemed like they might be relevant for your work as well. Who shall represent hospitals that are located in different regions of the state and that face different levels of financial stability. That was the same language that was in, and I think it would still may be relevant here. But they're the only ones who get 2 representatives. One representative of the FQHCs, who shall be a Vermont licensed healthcare professional selected by state. One Vermont licensed physician from an independent practice selected jointly by the Vermont Medical Society and Health First. I did take out a couple of references that were specific to rural settings from that list because I'm not sure they're as relevant here, or I'm not sure that's your focus here. No, they're relevant, so it's not your focus. One representative of Vermont's free clinic program selected by, it says because it used to be a different title, I changed it, by Vermont's free and referral clinics. One representative of the designated and specialized service agencies selected by Vermont Care Partners. one preferred provider from outside the VA and SSA system selected by the Commissioner of Health, Assistant Substance Use Disorder Treatment Services. One Vermont licensed mental health professional from an independent practice selected by the Commissioner of Mental Health. One representative of Vermont's mental health agencies selected jointly by the VNAs of Vermont and VIATA. And one representative of long-term care facilities selected by the Vermont Healthcare Association.
It's 14 people.
That's 14 people. I counted them because I dropped one that from the Rural Health Services Task Force that was at the head of the World
Right.
Medicine Program at UVM Medical Center that didn't see.
Starting to see this.
So, then we have the chair. Sorry, not the chair of the Agreement Program, but the Secretary of Human Services or designee shall be the chair. No co-chairs. And the Agency of Human Services will provide administrative and technical, and I struck legal assistance to the advisory committee. Getting close to the end here, ish. So in the group of sections, or it was a group of one, before on data integration, I have added data sharing, and you'll see why in section 11, but section 10, I just made the changes that we talked about as a result of AHS's testimony and Vital. So the Agency of Human Services shall collaborate with and just the Health Information Exchange Steering Committee in developing this integrated system. The agency's process shall align with the statewide health information technology plan. Delete the reference to building on the agency's experience in developing and implementing the unified health data space. Use the expertise of the Health Information Exchange Steering Committee. I debated whether to leave this in because they're collaborating with the Health Information Exchange Steering Committee, but I think referring to the expertise doesn't hurt. Incorporate, and the agency suggested deleting best practices forward, so that was fine, but just saying incorporate privacy and security standards seemed insufficient, so I said incorporate appropriate privacy and security standards. I do think the idea of not tying them to a specific point in time makes sense, especially as the standards themselves may continue to evolve. Determine how best to, and not incorporate, but integrate clinical data, claims data, dropping the reference to VCures, and data regarding social drivers of health and health-related social needs. Here's the language from AHS on interoperability, ensure interoperability among contributing data sources and applications to enable a unified health data space that is usable by all stakeholders. And a couple of renumberings. And then finally, in what is now number 9, identify additional opportunities for future development. And the including is including incorporating new data types and larger populations.
So, following up on this one, just a tad, just trying to understand what information will we get back, if any, unless we ask for it, regarding the work that's done.
There isn't, I don't believe there is a specific report back on this one, but we can,
Let's add something in there.
Yes.
Yeah, otherwise it just.
do you want ongoing reports or a one-time report?
Let's have ongoing.
Okay, because I'll put it in the, I'll put it in the statute if you want it to be.
Not report, it's presentation to, I think we don't want a volume every time. We just want to
Yes.
updates.
Yep, okay.
Updates.
It's just for the data.
For the work that's done. Well, we're getting it for other things, but this one we kind of left hanging. And then the other, that one is important.
Okay. Yes, there are more reports coming.
Yeah, my other question was, got clinical and claims data, and we're mandating that the state provide the data. How do we ensure that insurers or payers are providing data? Are we gonna be, is it all through claims? How do we ensure that we're getting all the data that's out there?
Well, right now their charge here is to determine how best to integrate data from various sources. So I think if they need an additional.
That's different. I mean, how to integrate it is one thing, but how do we make sure that it's being delivered? So that's not, so there isn't one little clump of private insurers over here not sharing data information about one or more patient types. Is that anywhere here?
That is not anywhere here.
And we ask somehow to have that happen.
So you want to direct insurers to make their, is it claim specific claims data?
Well, we would like to know that we have data, clinical data, from insurers.
Yeah, so I think I want to put in a different section because we'd be directing the insurers.
If we can do that.
Or maybe I could add it to this. Okay, let me
Think about that one.
Yep.
That was something that I think we had sort of talked about. But I hadn't gotten there yet.
So you want the clinical and claims data, or insurers to provide clinical and claims data to AHS for this purpose. Okay. Now we have, oh, I didn't finish. So in subsection C, the agency shall provide access to data to state agencies and providers as needed to support the goals of the statewide healthcare delivery plan once established. And then I've added, as recommended by Vital, to the extent permitted by the data use agreements in place for each data set. All right, 4 more pages and I could be upstairs in 3 minutes. So let's plow through it and then I'll be back at 9:30. Section 11 is a new section. This was requested by the board. So this is in their existing statute on, and one of their main existing statutes and deals with their subpoena authority. And so I've broken the existing language into subdivisions 1, 2, and a new 3. That would say the board may share any information, papers, or records it receives pursuant to a subpoena or notice to produce issued under this section with another agency as appropriate to the work of that agency, provided that the receiving agency agrees to maintain the confidentiality of any information, papers, or records that are exempt from public inspection and copying under the Public Records Act. So request move forward. Section 12 is the retaining accountable care organization capabilities section. So this now, instead of the agreement, care and blueprint, has the Agency of Human Services explore opportunities to retain capabilities developed by or on behalf of an ACO, and change the description of electronic health records to quality data measurement and reporting, and has on or before November 1st, the agency report its findings and recommendations to the Health Reform Oversight Committee. Then we've got some new sections on implementation updates, and these are not particularly detailed, so let me know if there's more you want in here. By November 15th, the Agency of Human Services will provide an update to the Health Reform Oversight Committee regarding the agency's implementation of this act, including the status of its efforts to develop the statewide healthcare delivery plan, advance healthcare data integration, and explore opportunities to retain accountable care organization capabilities, as well as on its hospital transformation activities pursuant to Act 167. Section 14 would be the Agreement with Care Board, and you talked about having them report by February 15th of 26, with an update to this committee and the House Healthcare Committee regarding the board's implementation of this act, including the status of its efforts to establish methodologies for and begin implementation of reference-based pricing and development of global hospital budgets.
Do we want to have the word report on these two things, or do we want to have?
I use the word, this isn't really how we are able to track reports. So that when Katie and I come in and give you the list of all the reports that are due to you, this is how we search documents to find where there's a report.
Okay. Senator.
Doesn't mean it has to be in.
I have comments on 13 and 14, but we can save those for when you come back. I just want to flag those for now.
Great.
Okay.
Section 15, we got the information from the board about what they need for positions. So the establishment of the following 5 new permanent classified positions is authorized at the board in FY26. one director of global budgets, one project manager of global budgets, one director of reference-based pricing, one project manager reference-based pricing, and one staff attorney. Section 16 is appropriations. So these numbers change. So I've highlighted them. I didn't strike and show new ones. But the amount here has gone up, I believe, from 500 to 550 to the Agency of Human Services, with 250,000 for grants to hospitals for transformation work. 100,000. So the full amount that was going to be split between AHS and the board was going to AHS for development of the plan, and 200,000 for contracts for consultants and other expenses. Still have 250,000 from the HIT fund for data integration. The amount to the Green Mountain Care Board has gone up from 1.3 to 1.5. They relooked at their numbers for the positions and are requesting 850,000 for the positions, still 500,000 for contracts, and 150,000 for expenses. And now, instead of associated with developing the plan, it's for increased standardization of hospital budget data submissions in accordance with Section 4. And then effective dates, the positions and appropriations take effect July 1st. Everything else takes effect on passage.
All right, thank you. What a lot of work in a short time. Thank you, Ben. I think it reflects the discussion that we had yesterday and previous days. So why don't you?
Yes,
come
Katie
back?
and I will switch places.
We're
Literally.
going to send you off and ask you to come back. And I know that Senator Douglas, they said a question about the previous.
Yeah. Yes, we will
Do
pull
it
the-
to you.
Yes, at least a few things, including.
Yeah. I mean, I can share this.
Yeah.
So when I brought those things yesterday,
Yes.
some of that only fostered meant it was half.
Language that Chad had provided us. We may want to talk about how those two things fit at some point
Okay,
or not, because you and I had talked about that.
okay,
Do we want Chad to come up?
that's what I'm wondering.
That's what I was just thinking.
Okay, let me know.
Chad. When we get to these places where we don't know whether we should go ahead first or we should hold back and wait until we get the information and how that all works. So it's not reflective of all the work that you've done. I really appreciate what you put together for us. So, and Kiki, do we have Chad's? Do we have your language that you sent to us?
Yes.
Yes. Thank you very much. Okay. Good morning,
Good morning.
for the record. You are.
My name-
Introduce yourself and then
Yes.
tell us what we have from you, the language.
Yes.
That'd be good.
Thank you, Madam Chair, thank you, committee, for having me back. For the record, my name is Chad BJ. I am the Chief Executive Officer for Recovery House Inc. In addition to that, I'm part-time faculty at Vermont State University at Castleton, and I serve as the president of the Vermont Substance Use Treatment Collaborative, a multi-agency networking and collaboration organization. Thank you for having me. So I submitted some proposed language for S36, and I want to walk you through three sections that we have. Most notably in section 1, some language changes included removing the term long-term residential treatment and replacing it with high-intensity residential treatment for substance use disorder and co-occurring.
We don't.
In subsection B of section 1,
Keep going. I'm just making sure we have your language on our page.
I thought it was important to reaffirm the provider's expertise when determining length of stay in a high-intensity residential treatment facility. And the language is reflective of that. It also has policy in there that the treatment provider shall take into account best practices for this level of care. I think that's important as well to acknowledge. Section 2 is an addition to S36, and what I've done there is I've split out our low intensity, what was previously referred to as longer term care, or 90-day program on average. So our low intensity residential treatment for substance use disorder and co-occurring mental health conditions. Similar language in terms of reaffirming that the treatment provider is responsible and most appropriate in determining length of stay. And again, including language that says the provider shall take into account current best practices. So nearly identical language, just separating the two levels of care. And section 3 is related to rate setting. This is similar language that AHS had proposed in terms of conducting a review of the payment model by July of 2025. But I've included a few items that Medicaid should take into account, which include the actual cost of providing service to an individual to commensurate with length of stay. So we do know that folks sometimes need longer lengths of stay at our most intense levels of care, and the reimbursement rate should reflect that. The second one is co-occurring medical and mental health needs. As it stands now, our episodic payment does take into account certain co-occurring disorders, certain medical conditions that require a greater deal of resources, and the reimbursement rate reflects that and should continue to. And the third piece is environmental needs for an individual's recovery post-residential treatment. A considerable amount of resources are needed to help folks transition out of homelessness through our facilities into a safe and sober environment. And we need to take that into account when we're setting. And those are the changes that are complete.
Good, thank you very much. Questions for Chad? Clear. Good, thank you. So let's bring Katie McClin up, and then Katie, did you, wait,
Yeah,
hold it, hold it.
Under section 3, environmental needs, can you elaborate a little bit more on what environmental needs refers to when for Medicaid reimbursement rates? Because could that mean like there needs to, like somebody wants a movie theater in a couple of residents, that's an environmental need, like, or how that could be like really restrictive. Yeah.
Yeah. So when I speak about environmental needs, what I'm looking at are specific diagnostic identifiers such as homelessness, loved one in the home that's actively using, environmental hazards, if you will, in recovery that are diagnosable under the ICD-10 that require more resources to address before individual use. So,
Senator Douglas's question, is it defined in statute, environmental needs, or is it defined somewhere?
Yeah, so let's wait and we'll ask this question of Ledge Council. That's good, thank you. And this is, we'll do that. It's a good question. You have another question?
Yes, I do. Since 30 days, 60 days. Is 30 days and 60 days enough, or do you need 180 days?
So in my proposed language, I have removed the 30-day and 60-day language.
Well, I know I have the.
Yeah.
I know I am, but that's what I'm asking.
So is
I don't have a copy of it.
Yeah, but so his stuff is on the website.
Yeah, we heard that you can't predict time. Every patient is different and you have to have variable either shorter term or longer term, depending on the patient needs. Yeah. Good, we're good.
Thank you.
Oh, we want to, Katie? We have a little bit of time with this one, so that's good. And Katie, I could not communicate with you about this, so we're.
Okay. I'm not sure what kind of timing I'll have for a redraft at this point this morning.
I do want to ask you a question about that.
Sure.
Understanding that the recommendation from why don't we look at what the recommendation from the agency department was? Is
Okay.
what we have there that you put together.
Sure.
And then it looks to me like the two could fit together, but you can, so that's one, will the two fit together? Because I think it sounds like a good idea.
Mhm.
I think so, but that's me. And then the other question is what Senator Douglas was asking and Senator Lewis was concerned about, which is environmental.
Okay, Katie McLean, Office of Legislative Counsel. So I was asked to take language that the agency provided and integrate some of the elements from Chad's memo. So that's what you're seeing in front of you for section 1.
Okay.
So the first section is a report back. AHS is to conduct a review of the Medicaid payment model for residential substance use disorder treatment services with special consideration given to the actual cost of providing residential treatment services commensurate with the level of stay, co-occurring physical and mental health needs, and post-residential treatment service needs. The results of the review shall be submitted to the House Committee on Human Services and the Senate Committee on Health and Welfare on or before December 1st. That date was at the request of AHS. And the review shall include recommendations and proposed legislation to align with the Medicaid payment model with clinical needs of individuals receiving residential substance use disorder treatment services and ensure coordinated transitions between residential substance use disorder treatment providers offering varying acuity of care. And then, as you heard in the presentation from AHS, there's language and statute that prohibits public inebriates from being incarcerated in an Department of Corrections facilities, and they ask that that language be repealed. There's underlying statute that would be retained, but this particular provision hasn't taken effect yet, and it keeps the date on that keeps being moved out every few years. So the ask was to repeal that. Section 2 does that. Section 3 has a corresponding change, and this is the sections 2 and 3 are identical sections that are also moving in miscellaneous judiciary bill. And then this takes effect on July 1, 2025. After passage, it would read an act relating to Medicaid payment model for residential substance use disorder treatment services.
So if we were to look at how what Chad has suggested before we get to the environmental question is to put in some language in Title 33 already, or some definitions and information. And then he's also put in the rate setting study there. Now, how is it possible to combine the report request from the agency with his recommendations?
I mean, they're pretty much asking the same thing. They're both asking for a Medicaid payment model review. I also don't know what environmental needs mean, and there is no definition. So
Why don't we just put down needs of, for the individual's recovery post-residential treatment?
Okay, so right now you have language. So this is language that was integrated from the memo. So the actual costs of providing, this comes from the memo to try to integrate those concepts into the rate study review. Actual costs of providing residential treatment services commensurate with length of stay, co-occurring physical and mental health needs, and post-residential treatment service needs. So that's an attempt to pull that language into the study.
And then. So my question of the committee is, we have two choices here. We have one where we go ahead with some language, statutory language that really helps define treatment and types of treatment, and then a report back about Medicaid payments and other payment issues. Or we simply ask for a report. I don't know that we need a report back on everything. I lean toward the language that Chad has brought us to put into Title 33 and then add.
Instead of the payment model. Instead of this section 1.
Yeah, instead of a report, we'll have the report. It would be good. Yeah, so. Hang on. Well, there's no reason why we can't ask it to be evaluated anyway. What are you saying? The payment model is what's being studied.
Yes, I'm asking
Yeah.
if you want the language, the proposed language, section 30 to Title 33 instead of this section 1. Or do you want?
Yes, and then the
Do you want
study
it
would,
instead?
it's, so. I want to model it after what Chad has given us. So he's given us some language, and then to have a study that includes the analysis that you've identified there.
Okay, so you want to keep this section 1 and add the language from Title 33 as well. Is that
Yeah.
correct?
Yeah.
Okay. Okay.
Can we do that? What's our time? We can take a break.
It's gonna take me longer than a break. I have to be in another committee at 9:15.
Okay.
It really depends how long the floor. I have 2 other amendments to write while the House is on the floor. So this is number 3. So if the House is on the floor for a while, I can do it. If we get cut short.
Do you think you would get back here before, on the floor at 11:30?
I could probably get an amendment back here, but I don't know if I physically could get back here.
Okay, well, let's get an amendment. We'll look at it and then somehow we'll collect with you. Either we'll talk us up on the floor a little bit.
Okay.
Or come in here. We'll
Okay.
set that up.
That works.
Okay. And you've got 15 minutes.
I have 15 minutes. I'll go get started.
All right. You
Okay.
can sit here and do that if you'd like, because what we're going to do is,